Hello, my name is Kristen Quinn. I'm a general surgery resident, PGY3. I want to thank SAGES for the opportunity to present our work, and thank you all for participating in this virtual meeting. I will be presenting our research on the laparoscopic versus robotic inguinal hernia repair, a comparison of resident learning curves and skill transference in general surgery residents at The Ohio State University Wexner Medical Center. This work was supported by the SAGES Robotic Surgery Grant, and the authors have nothing to disclose. Since its inception, the appeal of robotic-assisted surgery has persisted. For surgeons, the robot offers increased dexterity, precision, ergonomics, and 3D visualization. And for patients, it offers a shorter length of hospital stay and decreased blood loss. While laparoscopic surgery has well-supported training protocols and certifications, there's a relative paucity of training guidelines for the robot. Currently, many centers are duplicating laparoscopic guidelines to make a robotic curriculum. We set out to better understand and how the learning curve and achieving competency in these techniques differ. Furthermore, it is unknown how exposure to either of these minimally invasive surgical platforms influences performance in the other. With this in mind, we designed a study to better examine the differences in learning between these two modalities. Specifically, we wanted to compare surgical resident skill acquisition between robotic and laparoscopic surgery, for which we will evaluate and compare operative times between the modalities, measure resident mastery and improvement objectively by timing their active participation as the primary surgeon of the case, and subjectively via self-evaluation and attending evaluation. And two, we wanted to assess the transference of skill by examining the effect of laparoscopic exposure and training on residents' robotic performance and vice versa. Our approach is novel in its prospective observational study design. Our participants were general surgery senior residents at our large academic medical center, and the patient population were receiving the standard procedure of an inguinal hernia repair. Patients were included when they were either undergoing a lap or robotic repair. We excluded patients who had had a prior repair, complex repair, or a history of abdominal surgeries, or if they were getting multiple simultaneous procedures. Cases were observed by dedicated research assistant for operative time, percent active resident participation, or the amount of time that the resident was the primary surgeon holding the primary operative instruments, and the number of handoffs between the resident and attending. Case difficulty was rated immediately after the case by the attending. Residents completed a self-evaluation, and the attendings evaluated the resident's performance. We also had both residents and attendings estimate the percent of the case they felt the resident was doing. Based on our previous work on this topic using medical students as a model, novice subjects, we formulated two hypotheses. One, that there is significant transfer of skills from the lap to the robotic platform, and two, that there's a very limited transference of skills from the robotic to laparoscopic platform. And second, that robotic surgery has faster skill acquisition than laparoscopic surgery. That is, that residents would quickly be spending more of the case as the primary surgeon. These groups were well matched. There was no difference between patient age, BMI, ASA class, no conversions to a different modality or complications. We also examined a series of medical comorbidities, including diabetes, COPD, renal dysfunction, coronary artery disease, and there were no significant difference between the patient groups. Mean operative times and case difficulty between the two modalities were not significantly different. The average inguinal hernia repair took about 89 minutes robotically and 95 minutes laparoscopically. Cases were rated as medium difficulty at a score of 3 out of 5 for both modalities. This again demonstrates that the groups were well matched by both patient factors and operative time factors. There were significantly less handoffs with the lap modality compared to the robotic modality. Again, handoff was counted when the primary surgical instrument was handed off to the resident or handed back to the attending, making them the primary operating surgeon. We derived that more handoffs represents a more dynamic and active learning model. There were significantly more handoffs on the robotic modality, about 9.7 times per case, while on the laparoscopic modality, there were only about 6.3 handoffs per case. And about resident active participation. The resident performed 66% of the case when using the robotic approach versus only 37.26% of the case in laparoscopic modality. Residents' active participation, also known as the percent of the time that the resident was the primary surgeon or holding the primary operative instrument, was significantly higher with the robotic modality. During robotic cases, they were the primary active surgeon during well over half of the time on average. However, in laparoscopic repairs, just over a third of the time. We asked, could this be due to differences in attending preference? However, focusing on just the attending surgeons who operated on both modalities, we demonstrated the same differences, with residents primarily operating 74% of the case time and only 48% of the case time laparoscopically. This analysis helps eliminate the chance that the decreased active participation was attending dependent and supports our hypothesis that this significant difference is modality dependent. We compared the resident questionnaires across modality to the attending perceptions. We found that residents perceived that they were performing more of the case or were the active participant in significantly more of the robotic cases than laparoscopic cases. Residents felt they were the active participant about 63% of the time, compared with attendings who felt the resident was the active surgeon 71% of the time in the robotic modality. For lap cases, the residents estimated they were active only 30% of the time, while attendings felt that they were doing about 47% of the case. Attendings in general believed that the residents were performing substantially more of the case than residents felt. So who was right? We compared subjective perceptions to the actual operative time that residents were the active participant in the case. Residents' perception was a closer match to the measured actual percent active time. Interestingly, the residents underestimated their actual active time and the attendings overestimated the time that the resident was active. Skill transference was measured by examining residents' prior exposure and then their active role in subsequent cases in each modality. The robotic platform saw a strong positive correlation between active resident participation and prior robotic experience, suggesting that residents with more robotic exposure quickly took on more of the role of active surgeon. Those residents with prior laparoscopic exposure also saw a percent higher active role in the case, but with a weaker correlation. Prior robotic experience very minimally impacted how much of the case a resident would do laparoscopically, suggesting that despite acquiring robotic skills, they were less likely to apply those skills to a laparoscopic case. Skill acquisition was evaluated by looking at specific repeat residents' performance on subsequent cases, either lap or robotic. This was our surrogate for evaluating the learning curve with the assumption that 100% case active time would represent mastery. Residents were able to be the primary surgeon for larger amounts of time in subsequent robotic inguinal hernia repairs. Remarkably, however, in subsequent lap cases, they did not seem to be acting as primary surgeon more often. Their participation appeared to hold around 35%. While very limited and unable to show complete mastery, this data points to a revealing trend. Residents quickly grow in their ability to perform the surgery robotically, while at least initially, they may require more laparoscopic repetition before being able to perform more of the case as the primary surgeon laparoscopically. In conclusion, during robotic cases, there were significantly more handoffs between the resident and attending. We believe that this may be due to the ease of switch and represent a more dynamic learning model. Residents were the active participants for a significantly longer percent of the case robotically versus laparoscopically. There was a greater degree of skill transference observed from the laparoscopic to robotic modality than compared from robot to laparoscopic. And residents became more rapidly the active participant in robotic cases than laparoscopic cases with serial experiences, which may represent a shorter learning curve. Overall, this is an initial exploration into surgical learning and skill acquisition, and very few studies have looked into it this way. We're hoping to continue this work. These results encourage training programs to treat these platforms as independent modalities requiring distinct educational guidelines. Showing skill transference from the lap to robotic techniques suggests maximizing trainees' experience with the laparoscopic skill prior to embarking on robotic training. And faster ascent in active participation with the robotic platform suggests that trainees may not need the same level of repetition to meet competency in robotic assisted surgery as in laparoscopic assisted surgery. And this is important for training and privileging purposes. Thank you so much for your time. And again, thank you for this opportunity.